Hi, good evening. Thanks for joining us here again tonight with Aortic Athletes. My name is Carmen David. I'm an aortic dissection survivor and an aortic athlete.
And my name is Jack Crow, and I am an aortic dissection survivor also, and an aortic athlete.
Well, we just wanted to share how much that we love this community. This Aortic Athletes is really becoming a movement from people all over the world who have aortic disease, who are exercising, and who are following the science and therefore assisting the medical community in improving that science.
That's right. And Aortic Athletes, we're a peer-to-peer support group on Facebook. Our motto is don't quit, adapt. And please join us. Join us at Aortic Athletes and join Aortic Hope as well on Facebook. And you can click on like on this video down below and AI will send it to everyone, even Elon Musk.
Well, you see our guest here tonight, but before we get to Dr. Siddharth Prakash, we want to remind everybody that this is an information that we discuss here tonight is for educational purposes only. We don't provide medical advice or treatment, diagnosis for treatment of aortic disease. Instead, we encourage everyone to see their cardiologist for medical advice about your exercise with your aortic disease.
And Carmen, that's because each of us is unique in our journey with aortic disease. So, who's our guest today?
Well, I think by looking at him, mostly he does not need any introduction, but this is Dr. Siddharth Prakash for those who do not know him. He is a professor of internal medicine at the University of Texas Health Science Center in Houston, Texas, where his research focuses on genetic causes of bicuspid aortic valve and related congenital abnormalities involving the left ventricle and the aorta.
And his clinical specialty is cardiology and aortic imaging. And I should also note, Carmen, that your run for aortic health raises money that has gone to Dr. Prakash for some of his studies. So this is old home week.
Yeah. Well, yes, and that's the case. Since 2021, we started sending money from the race to Dr. Prakash for his new study. And so we're pretty proud of helping a little piece of helping out with that, but he's doing all the hard work. So several years ago, Dr. Prakash, you launched this first ever clinical study of aortic dissection patients and exercise. So do you have any update for us on that study? Where are we with that?
Oh, first of all, I want to thank both of you for that tremendous and kind introduction, and welcome to all of our listeners around the world. I indeed have been interested in exercise for about 10 years. It came out of the work that I do in our clinic. I'm the cardiologist in our aortopathy clinic at UT Health Houston. And I manage all kinds of patients with different types of aortic disease. The one question they always asked was, is it safe to exercise and what kind of exercises could I do? So to answer that, we really started to get some data because there really weren't any studies out there to answer that question. And so we decided we needed to answer that question for ourselves, for the community. And in doing that, we ran a series of studies that have culminated in the clinical trial that you mentioned. The clinical trial was supported by the John Ritter Foundation and Carmen's funds. And with their help, we have recently completed the study and we are currently analyzing the data. And I can tell you the main thing that we learned is that yes, indeed, moderate intensity exercises are safe. And they do appear to lower blood pressure in all types of patients with aortic dissections. And there were no adverse events or effects of exercise in our cohort of 100 patients. So we're really proud of that because when we started this study, it wasn't clear that people believed exercise was even safe for people who have had dissections. So we're able to show that. And we're continuing to analyze the data to look at things like mental health, quality of life, and other indicators of overall aortic health.
Well, Dr. Prakash, that is a relief. That's a woo-hoo. for aortic athletes out there around the world that we've at least begun to put our arms around something that's tangible to say that it's safe. And it sounds like, at least as to, is it both aerobic activity and isometric stuff? Is it just aerobic? What is it? So in the study.
So I'm so glad you asked, Jack, because we specifically wanted to address the question about which types of exercise were in fact safe, since there are so many myths out there about exercises you should avoid or exercises you have to do differently. So we designed our study to include both resistance or isometric exercise and aerobic or moving exercises, and equal measure, actually. So these were both at both moderate intensity levels. And again, they were 100% safe in our group. So I think we did answer a lot of questions in terms of the types of exercise that people can also do and expect to be safe in.
And 2 years later, I'm still doing the same exercises 4 times a week. I just keep doing them. I don't know. It's just become a routine. So it's
great.
It's good. I think it helps my back. And what is going to be next? Like I got to tell you, our goal at Aortic Athletes someday, our dream is that there will be a guideline, a standard that's generally accepted in the cardiac community that probably doesn't exist today, because I think you're still going to change some minds with your study. So what is the next step from a research point of view?
Yeah, so the next step in my mind is quite clear. What we're trying to do now is with the knowledge we gain from the study we've done so far, we're going to take that and combine that with all of our friends and colleagues around the country who are doing similar work to do a large home-based study of exercise for all types of people who survived aortic dissection or who have not been exercising and want to stay active with aortic disease. And the goal of this study is to really reach out to everyone, including people who can't get to the hospital, by making it 100% home-based and also making it affordable, and also using new technology so that we can actually extend our observation directly into people's homes using smart devices and frequent contacts and even artificial intelligence. So we're trying to build it so that we can reach the most patients in a cost-effective way all over the country and get a very robust study of patients we can follow for years to really figure out, is exercise not only safe, but can it actually be a treatment for aortic disease? Can it actually improve patients' medical history going forward?
I think that sounds amazing, because I know a lot of times people were wanting to participate who just were too far away from Houston to participate. So I think that's very promising that more people can get involved and hopefully do this from home, like you said. So what is it going to cost? What are we looking at for this to be funded?
Yeah, so this would be a large-scale study. So we're talking $3 to $5 million in order to mount such a trial. It would involve multiple centers, each with their own kind of data coordinator. So quite a large effort that will require a lot of different infrastructure, and that's the reason for the cost. We are hoping, of course, to get some sponsorship from different types of companies that are on the market now with devices to track fitness and exercise. And that would partially defray some of the costs, but it's still going to be quite a massive undertaking. So we will need careful planning, and of course, it'll be a many year study as well.
And reading in the press, there's been some changes in the National Institute of Health funding. Looking in the tea leaves, is that going to affect this, do you think, the timing?
So the answer is it's unclear. I think we're in a state of limbo with respect to what's going on at the NIH. However, there are some alternatives. In particular, the American Heart Association has funded studies of exercise after myocardial infarction and have shown a keen interest in this area, actually. AHA funding is, of course, not affected by the current downturn. And so what we're hoping is we can use a variety of methods going forward to fill in the gaps.
Would that include people in watch and wait as well as dissection, do you think, or will it be just
Yes.
dissection?
We plan to enroll all types of people because we don't really know if there'll be a different effective exercise depending on your diagnosis and prognosis. And we want to be able to understand, do we need to adjust the recommendations based on your specific diagnosis?
And when you're ready, I hope you'll come back to the aortic athlete community, because my hope is that there's some philanthropic role that we may be able to play to help this, because we're deeply invested in this, and we want to participate in a variety of ways, right, Carmen?
Yeah, definitely. That's
Yes,
why I started doing it too. And I know there's a lot of other people who are really interested in helping in any way that they can.
We're so grateful for everyone who supported the studies so far, and of course for your help, Carmen. And of course, certainly getting to this point requires a lot of teamwork. It wouldn't have happened without all of you.
Awesome. Well, Jack, do we want to go over start with the athlete survey?
Yeah, tell them about the survey.
So if we can go over some of the results of the aortic athlete survey from the summertime, there were about 250 aortic athletes who answered questions about their experience with aortic disease, exercise, and advice that they had received from their doctors about exercise. And and so we'll go over some slides about that, but we also have hopes to put a new survey out this summer with input from people like Dr. Prakash and his team as well. So let me get to Josh. I think I'm ready to share these slides. And then Jack, do you want to kind of let me know where you want me to go with it?
Yeah, I mean, the first thing is we just threw this survey together ourselves. This is like, hey kids, let's put on a show. So imagine with input from Dr. Prakash and some of his colleagues, I'll bet we can do an even better job in 2025. So hopefully this summer we'll come out with a new study. But all that said, some pretty interesting findings from our group we have like 1,200 members from around the world. We got about 250 people to respond. And Carmen, that first slide, I think, just shows the variety of activities people are engaged in. And the biggest activity of aortic athletes is walking. It's not running ultras, it's not skydiving, it's walking. And the other activities, it's interesting, I think the vast majority of activities are aerobic too. And with things like weightlifting being more like 10%. Is that, I take it you think that's a good sign, Dr. Prakash?
Yeah, I think that we should actually encourage more different types of activities and be more positive in our recommendations. In the past, it was always focused on what people couldn't do, especially what they heard from their doctors. And so I think we need to reorient ourselves and ask, what are people doing like you are? And also, how can we make those activities safe rather than just saying, no, you can't do that, because that doesn't reflect how people actually live.
Uh-oh, Carmen's on mute.
Carmen, did you mute on purpose? And while we're taking a quick lull here, let's get into some questions here.
Sure.
Right away. Hello, everyone. Tom, Julian. Julian here has a statement. The new guidelines send a strong message that exercise is good for all of us, and we should stay active. Hold on a second. No, I am unmuted. Okay. And we should stay active. On the other hand, they say some of us should not be taking part in competitive sports. He also says, big question, when does exercise become competitive sport? Is this a question that can only really be answered for individual cases as part of shared decision making?
Yeah, so I think a lot of that, what he said is true, but there are some definitions of exercise intensity that are based on physiology. And the reason why we, for example, advise even for recreational activities not to proceed with them until the point of exhaustion is because we know that in the last moments before you begin to fail at your exercise, you become exhausted, the blood pressure really increases and the stress on your body increases. And so that's when exercise crosses over from a healthful recreational activity to an intensive, potentially harmful activity. And we need to be mindful about that with all types of exercise, not just competitive exercises. And I think the competitive exercises that most of us as cardiologists are concerned about are, of course, contact sports and things that involve large amounts of weight shifts or sudden decelerations, because those can impact the blood vessels. Aside from that, you're right, a lot of it is based on shared decision-making and openness between the doctor and the patient, and the ability to adjust based on a person's desires and targets for their exercise.
And Dr. Prakash, can you give us like is there a thumbnail definition of vigorous exercise? Let's call aerobic versus moderate exercise. Because Carmen, if you go to that third slide, one of the interesting takeaways from this survey is that before people join Aortic Athletes, almost 40% are exercising vigorously at exertion levels, but that after they join and they meet the group and they hear from people like you, almost all those people switch to moderate level exertion, which I think is that's a win, I think.
Yeah, so there are many ways that you can define vigorous. It's not really a scientific term, actually. And so the way we have done it for the clinical studies is what's called a rating of perceived exertion scale, which has been used for decades. It's also known as the Borg scale. It depending on which one that you use, we use a modified one. There are different numbers, but ours scale goes from 1 to 10, and it basically asks the person to rate their exercise intensity, where 1 is just doing nothing, and 10 is the hardest exercise you've ever done in your life. So it will be very subjective, but the idea is that if you apply the same rating scale over time, you can adjust your activities. And by that scale, 4 to 6 is moderate, and 7 to 10 would be high intensity exercise.
I just want to plug in there. There was a woman named Shannon on the group that did ask about that. So I'm glad you went over the Borg rate of perceived exertion, because she was asking about not really getting a clear understanding what measures to follow when it comes to her rowing and paddling, and wanted to know, what the measure on her rower should be. But like you said, that was a good explanation of what your exertion rate is.
Yes, and I think that's particularly relevant to the athletes, because a lot of them have a lot of experience at different levels of exertion. And so they would be able to tell for themselves quite accurately where their limits are. I always tell people who do not have a lot of experience with exercise, really the key is to start low and go slow. That is, you want to start at a low level of exertion and gradually ramp up. You don't want to go near what could be your maximum right away, because that risks the potential to exhaust yourself and get into trouble. So it would be better to start something that you will feel comfortable with, and then gradually increase the intensity over time, so you can learn your limits as you go.
Okay.
And would you apply that to?
Hold on, Jack. And Carmen, you're not really sharing the slides. I'm not sure if that's what I was waiting for, the slides to show up.
Oh, am I not doing it right?
Yeah. Go back down to the taskbar and then find the slide deck, and then click share this screen.
And while Carmen's doing that, Dr. Prakash, some of one of the questions that we got from an aortic athlete was about, I'm doing yoga. First of all, is yoga okay? But I'm also doing plank. Is plank okay? And then, can I hold it for a minute or 2 or 3? And then I think the person said she had a relatively small aneurysm of 4.0 or something like that. But I assume the same advice would do it little by little. Make sure you're breathing. Don't just jump into it and hold something for 10 minutes.
Yeah. So when we talk about isometric exercise, where you're contracting your muscles but not moving in space, then it's really important to pay attention to your breathing. You want to breathe at a normal rate and not hold your breath. If you hold your breath while you contract your body muscles, especially your legs and your abdomen, drives up the pressure inside your body quite substantially. So you want to be free breathing. And if you reach the point where you can't free breathe anymore, you need to stop. Now, obviously, that will change over time as you become more acclimated to that exercise. But that should really be your guide in terms of how long you can hold it. If and that will be different for every single person.
Yeah, and I had a yoga teacher who said, be generous with your air.
Yeah, you really want to be able to take deep, unstrained breaths during contractions so that you know that you are not putting additional stress on your blood vessels.
Can you explain what vinyasa flow is?
So
for yoga?
For yoga, I'm not a yoga person, and I'm not really authorized to, or I don't have the experience to give you tips on yoga. But I can say that a lot of our patients do yoga, and it's fine. We typically recommend. The good thing about yoga is that it's frequently chaperoned, and so if you're starting out in a basic exercise class like that, you have it with an instructor who can guide you. It's actually a safe situation. It's similar to going to the gym and having a spotter for machines or a coach. So I think in many ways that is a better situation than trying to do it by yourself.
Yeah, and just from a layman's definition, the vinyasa is flow. So you don't hold any position. You're always moving through it. So there's less rigidity and tension. Hatha yoga tends to be like you're holding a position sometimes till your muscles shake.
Yeah. So the answer would be you would have to modify based on your ability to sustain the position. Obviously, that will be much shorter for beginners. And so I think there are two things to take away there. One is really understanding your limits, but also being in an environment where you feel comfortable being able to do those kinds of modifications, because there can be pressure to do what everyone else is doing. It may not be right for you.
Gotcha.
Okay,
hey, so guys, I was going to go back to the slide. You want me to go back to the one just to show if I wasn't sharing it right?
Yeah, yes, please, because I would like a breakdown of that first slide, but also that point about having yoga be there with somebody that's watching over you leads into this other question. So Julian asks another question. What does an EAP look like for aortic risk? Is there something beyond CPR and AEDs that sport event management teams should know about?
Great question. So obviously for aortic risk, we counsel people a little bit differently in that having an aortic dissection can appear outwardly very much like a heart attack. So the first thing most people will think about is that someone who's having a dissection is having a myocardial infarction or a heart attack. And of course, the two are very different. So we do recommend that people educate those around them about their risk and let them know that they're at risk for dissection, first of all. And the second thing is that when emergency responders come, it's very important that they know, because the treatments are very different. And a treatment for a heart attack can make the dissection worse. So the key is suspected dissection, get the test for a dissection, which is an immediate CAT scan at the closest available facility to get the diagnosis, and then get treated at a hospital that has surgery capabilities. So those things are a little bit different than just the standard kind of emergency response criteria that we would normally give.
Thank you, Doctor.
Sure.
Also, hi Velda, hi Molly, welcome to the chat.
And a shout out to Julian, who I think is pulling an all-nighter in London, if he's watching this live.
Yeah.
Go, Julian.
Okay, Carmen, why don't you ask about fear?
Fear. Well, I was going to say, yes. So the other big takeaway that we got from the survey, well, first, let me do this first. So you can see the first slide, primary exercise being walking that we talked about. And then slide 2 here about the vigorous activity, you know, about 65%. And then actually, sorry, that was this one. Before it was 30, almost 37%. And then after joining and hearing educational material such as this, they swapped to a more moderate level. Since we didn't get to those slides. And then here, experiencing fear. So the other big takeaway was from about 70% of people with aortic disease experienced fear of exercising before joining the group, but that afterward, about half of those people felt less fearful after they joined Aortic Athletes. And so the question is, and Dr. Prakash, do you think that social media can play a role, is this really showing this to us, play a role in getting the word out about what is safe and what is not for folks? And here's the other slide of what they experienced, you know, after the fact, that they were less fearful.
Yes, Carmen, that's a great point. And I think that the value of community is extremely important in aortic disease, both in the context of exercise, but also in the patient's journey, because you may be the only person you know who has aortic disease. And so feeling isolated is definitely anxiety provoking. And it also causes uncertainty because you don't have any examples of anyone who's doing things that you need to do. So building a community around exercise and positivity is really important. And we certainly try to support that. There are a variety of programs that our groups do to try to bring people together around aortic disease, from like mentorship, guidance, facing a diagnosis. And I think doing this around exercise, like your group is doing, is going to be the future. And something that we will try to do in our clinical trial for sure is to build a community of people who can support each other. Because when you're sitting at home and without access to a lot of these things, it could be a lifeline to really help you feel positive about yourself and engage in exercise.
But I think really though, our social media initiatives and Facebook peer-to-peer support group like Aortic Athletes, it's an empty gong if it's not filled with sound science from folks like you and others who are generously, sharing your evening with us to spread what really is the state of the science. There's a lot of bad information out there. By the way, Dr. Prakash, your fellow cardiologists are not clothing themselves in glory in answering what part of the survey was, what do you recall hearing from your cardiologist about exercise? And the answers were all over the map. Some were great. Some were exactly what you're telling us here tonight. Some were never lift more than 10 pounds for the rest of your life. Some was, don't even worry about it, do whatever you want. So that's why we're really hoping we can get to the point of guidelines that can form the foundation.
Well, and Dr. Prakash, so you have put together exercise guidelines and posted on the John Ritter Foundation for Aortic Health site. So thank you for doing that one. But do you think these guidelines are something that one day will be accepted by the cardiology community? And what is it going to take for us to really get there?
Yeah, so guidelines have a very high burden of proof. In general, in order to change the guidelines, you need to submit what's called level 1 evidence. Level 1 evidence is a randomized clinical trial that involves large numbers of people who are followed for a long period of time to see if a treatment really works or not, and to evaluate all the risks. So that's what we've been missing in the exercise field for aortic disease, is really a large-scale randomized trial. And so my hope is that if we're able to carry this out, it will be the basis for the next guidelines to change the opinion about exercise, citing this as evidence.
So then maybe once it's posted in these AHA guidelines or whatever the cardiology place is to go, that would be the changing nationwide or globally that we're looking for?
Yeah, exactly. So there are two kinds of guidelines that apply to people with aortic disease who are exercising. One of them is the sports participation and activity guidelines that are run by the AHA and ACC, and the other is the aortic disease guidelines. Of the two, the sports participation and activity guidelines carry more weight because they apply more broadly to everyone, but they do have a section on people with aortic disease.
And they were just recently revised, I think, weren't they?
Yes, both of those are revised every 5 years or so. And so our hope is to carry this out in time for the next guidelines so that they will be considered in their evidence.
That's what we're hoping too. And we're going to put a link, Joshua, to the Ritter Foundation guidelines, and maybe we can ask you a question or two about those. You talk about controlling blood pressure, as a person starts engaging in an exercise program. What does well-controlled blood pressure mean for our community? What are we looking at as far as numbers, and why?
Yeah, so there's actually good evidence that controlling the systolic blood pressure to 120 or less does improve outcomes in patients with aortic disease. It's been looked at in the context of surviving aortic dissections or preventing the need for future aortic surgeries. And the higher the top number on your blood pressure or systolic blood pressure is, the more likely those patients were to either have a dissection or require more surgery over a period of 15 years follow-up. So we do think that rather than the general population guidelines of 130 or less for systolic blood pressure, we do recommend a lower target if people can tolerate it for people with all types of aortic disease.
And then just to follow up on that, and Carmen, I'll turn it over to you. What about the exertion part of it? Because blood pressure is going to go up when we exercise for most people. And so are there limits? Are there reasonable limits for either aerobic or isometric or weight kind of activities?
Yeah, so we have a lot of evidence in this area too, although not for aortic disease specifically. So it may seem counterintuitive to recommend exercise when your blood pressure is going to go up while we're saying that your blood pressure has to be really low. But keep in mind that people exercise for only a fraction of the day, and the other 23 plus hours of the day, your blood pressure will be lower after you exercise. We know this because we've studied a lot of people who have exercised, and in the 24 hours after they finish exercise, their blood pressure is on average 5 to 10 millimeters lower than it would have been if they did not exercise. So the net effect of exercise is actually to lower blood pressure, even though your blood pressure may go up during the exercise. Also, we know that blood pressure can go up to around 160 or 170 millimeters of mercury in routine exercises without causing any harm. It's those people who really get up above 180 to 200 and sustain that level for a long period of time that were shown to have poorer outcomes in terms of more cardiovascular complications later in life. And so we do pay attention to the top number as you exercise, but for the most part, it's rare to achieve that kind of change, especially if you're on a blood pressure medication. So that's the good news. And there are things we can do about it. If we do see a high number, we can treat people to lower that number.
So along those lines, so a person had asked, Mary Ann, you kind of already mentioned, she's asked, is it okay for the BP to spike momentarily? And then what's the length of time for it to come down post-exertion, which you kind of just answered. But she asked, like, how do you build cardiac fitness when you can't push your heart rate zone too far, for example? Or is she still building her cardiac fitness by remaining in these guidelines that you just mentioned?
Yeah, so the idea is that with regular moderate exercise, you can adjust the time of exercise as you build up more tolerance so that you stay in that moderate zone for longer periods of time and build up your endurance. We also know that the longer you're able to maintain moderate exercise, the greater the benefits are. So when we look at how long do you sustain lower than normal blood pressure after exercise, if you are able to exercise longer, that period when your blood pressure drops after exercise persists longer, and therefore the benefits of exercise increase. So it's not necessarily related to the intensity of exercise, but the amount of time that you're able to be in that moderate zone.
Which is why the 45 minutes to an hour, or whatever they say, is like a recommended time period?
Yeah, so the current guidelines are really vague about how much time at one time you need to exercise. It's more of a weekly goal of 150 minutes, which is moderate intensity exercise. And that understood to be spread out over many days. At least 3 to 4 days a week is what most people take that to mean. That means that at any one time, it could be 30 to 45 minutes at a time. But there's that is a minimum. And there's certainly no expectation that people will stick to that. As you get as your fitness increases, you may exercise for longer periods, as long as you're remaining safe within the guidelines that we talked about before.
I just want to check Joshua. Joshua, we got a lot more to cover, but I wanted to see, is any question out there?
We've got some follow-up statements. Julian would like you guys to know that it's only 11:30 p.m. there, so he's still awake.
In London. Hi, Julian.
And also, he says, and I totally agree with Dr. Prakash that disclosing conditions to trainers and event organizers and educating them is the key when we know we're at risk. Back to you.
Yeah. And so a related issue is stability. So I assume that if someone's aorta, whether they're in watching weight or like Carmen and I have dissected, the longer we're stable, the better. Like if we've been stable for 6 months or 12 months, or Carmen's going on 10 years now, I think. I assume, it's easier to give Carmen advice than it is someone who was diagnosed a month ago. So how does stability and chronicity or length of time play into exercise?
Yeah, so one of the things that's important if you are starting to exercise, maybe you haven't done it systematically before, is to get your aorta checked out thoroughly, because for that reason, we want to make sure that your aortic disease is not changing rapidly. By rapidly, I mean you should not be able to detect a difference within 6 months in your aorta. If your aorta is visibly changing, on a scan, from one time to another within 6 months, that's pretty fast. And so we would want to make sure that your aortic disease slows down before you begin an exercise program, because then you're putting more stress on an organ that's already changing rapidly and introducing potential risk into that situation. So that would be that's one of the most important recommendations, is to know the status of your aortic disease and make sure that you get it checked before you start exercising, for both what is it doing now and has it changed in the last 6 months.
And along with that, do you recommend like a stress test along with that if somebody is trying to get back into exercise or start?
Yeah, so I actually recommend a trainer if you can do it, or to have some sort of rehabilitation. So if someone, for example, has had a dissection, then we know that cardiac rehabilitation is safe and effective, and that's a supervised environment where they can start to exercise and get trained and make sure that they're doing it safely under and have their blood pressure monitored. So that's the ultimate, kind of the gold standard if you've been newly diagnosed. If you're not able to, then having a trainer or someone else who can watch you when you're starting exercise is the safest option. But I don't recommend people go off and do it on their own when they're just starting out, especially when they're newly diagnosed, because there are a lot of variables, and many times feedback is very effective in getting people to exercise with these techniques we're talking about, and reminding people about proper breathing and other kinds of methods that you can use to reduce the strain on your body can really pay off over time, even if you only use that guidance temporarily.
So another topic you want me to do the beta blockers, Jack?
Go ahead.
So another topic that
this is the least favorite drug in America.
Yes.
Go ahead, Carmen.
So it's not a fan between or amongst all the aortic athletes. Beta blockers always make us feel tired and unable to really increase our heart rates, and then we feel sluggish or lethargic before we're even exercising at all. So, but your guidelines recommend that we do take beta blockers. Can you explain why that is important for us?
Yes. So beta blockers are one of the few drugs that have been shown to improve outcomes in all types of people with aortic disease, particularly after aortic dissection. And they work not necessarily by only by blood pressure and heart rate, but they actually decrease the stress that the aortic wall feels with each heartbeat. They slow the force and speed of heart contraction, and that pulse wave that you feel when you feel your wrist or your neck, that is the force of that blood pushing outward on the aortic wall. And you could imagine that if that force is stronger, it causes more risk to someone that has a dissected aorta. So the goal of beta blockers is really beyond just heart rate and blood pressure. It's really to protect the aorta at a time when it's very vulnerable. Now, having said that, it does cause a lot of fatigue, and the younger you are, and particularly young men, it causes a lot of fatigue and they don't like taking it. However, I found that there are many options. So most people aren't aware that there are more than a dozen beta blockers. And in some patients, I've gone through 10 of them, right? Eventually, we found one that works. It actually, the response of an individual to any beta blocker varies widely, and we can usually find one that you can live with. So my advice is, if you're not liking your beta blocker, trade it in for another beta blocker.
And does the dosage get tweaked over time or no?
Yes. So in the clinical studies, people who were taking at least moderate doses had the biggest benefits. So whenever someone finds a beta blocker they can tolerate, we always try to push the dose as high as it can go, meaning if their heart rate doesn't drop too low or they don't start feeling dizzy or fatigued, we try to increase the dose as much as they can live with.
And weirdly, 2 years after dissection, I finally stopped being exhausted by beta blockers. It was like the sun came out, and I guess over time your body just gets used to it.
Yes, a lot of times it will happen. It is very hard to convince people, though, that things will get better because nobody likes to take it, and it is true that it can be very rough on people. But I try different things. So I give them 3 to 4 weeks to try it out, and if they're completely miserable, we'll say, well, let's switch to beta blocker number 2 and try that for about a month. And usually that gives people, at least they're willing to try it, and it makes them feel like we're making progress. And as I mentioned, most of the time, if we do it long enough, we can find a medication that works for them.
Well, and your willingness to do that, I think, and your sensitivity to sports, maybe not all cardiologists are up for that kind of fine tuning. So we really appreciate that. Now, one of the guidelines also talk about heart rate, and they say 80% of your maximum heart rate, and you can figure that out roughly by age and whatnot. Is there a correlation between heart rate and blood pressure, or are they two different worlds? Because I assume we're just trying to avoid blood pressure spikes. That's the whole goal. Yeah. So what's the relation between the two?
In people with aortic disease, there's almost no relationship between blood pressure and heart rate. It's not predictable. So you can have a very low heart rate and a very high blood pressure, which is not uncommon because people, as we mentioned, are taking beta blockers. So it pushes your heart rate down, at least at rest. It also makes it very hard for you to get your heart rate up to where it used to be when you weren't taking beta blockers. So if you use that standard, you're never going to be accurate in terms of your effort level, because you could be exerting yourself at an 8 out of 10 and have a heart rate that is really half of your previous maximum. So it would be nowhere near the maximum heart rate zone, but your exertion would feel like it's very intense. And that's why we don't rely on heart rate zones to monitor exertion. We relied on self-reported perceived exertion scales.
Yeah, I'm glad you mentioned that. Another thing, just to go kind of back just a hair, there was another question from Marianne about her GP wouldn't put her on medication, saying that it might make her BP too low. And I do know that there may be cases like hers or people who have exercised enough to maybe lower, or for whatever reason, they are maintaining about a 120 over 70, 80 blood pressure. Do they still need to be on beta blockers if their blood pressure is controlled?
The answer is yes, because we're doing things besides blood pressure control with beta blockers. We're trying to protect the aorta. Um, the big risk with exercise in terms of blood pressure is actually low blood pressure. So I'm glad you brought that up. A lot of our patients are on more than one blood pressure medication. It could be on an antihypertensive as well as a beta blocker. And then when you're exercising and you stop, your blood pressure, as we said, normally drops. But in these folks, it can drop quite substantially. And so one of the things we found in our survey of the aortic athletes is that people reported a lot of dizziness and fainting kinds of spells after exerting themselves. That's pretty common in this population, and people need to be aware of that. There are several things that we can do to help prevent serious events like people fainting at the end of exercise. But the most important thing is awareness and being well hydrated. And also we can adjust medications around the time that we know someone is going to be active to make that less likely. And we do that in several ways, but one of the things that we do in our clinic is 24-hour ambulatory blood pressure monitoring. So we can tell how people's blood pressure responds to activity and anticipate that will happen.
Well, and I'm one of those people who, after every run, when I quickly take my blood pressure, it's pretty low. I don't feel dizzy, but it's low.
Yes. Yeah. So we want people to be safe. And if you feel that that's a possibility, there are ways to kind of ramp down. So cooling down can be very important. You don't want to just suddenly stop. If you're going at moderate, you want to cool down at least 5 to 10 minutes so that your body can adjust and you don't start to feel lightheaded. And most people can kind of figure out when that's going to happen to them and begin to adjust their routine accordingly.
Dang, so no more sprinting to the finish line.
Well, you can sprint, but then you just have to jog for a little while.
Okay.
Well, I was going to ask, so you mentioned about the heart rate and blood pressure not necessarily correlating, especially when on medication. So a lot of patients will say like a doctor's told them to stay between 70 or 80% of their max heart rate. So is that still something that we should try to go by? But then the Borg scale, like how are we supposed to actually measure like what's moderate to us or what 80% really is?
Yeah,
While
so
taking
50
beta
to 80,
blockers.
50 to 80% is what's called the moderate heart rate zone. And so that's going to be your Borg 4 to 6. So if you're staying in that 4 to 6 range, that's roughly equivalent in terms of exertion level to a 50 to 80% heart rate would be for someone who doesn't have aortic disease and is not taking those medications.
Okay.
We have a question from Copenhagen. And he's an amazing guy, Torbjorn Sindball, who's a former professional Ironman triathlete. He went to Kona. He was on podiums professionally and stuff. He had a bicuspid valve and some dilation, and then 15 years of watch and wait. And 4 months ago, had surgery, and we just interviewed him. But here's his question: and he's a smart guy. What are we trying to prevent from happening using exercise guidelines? Is there long-term data on the risk of dilation, dissection, or rupture, particularly whether it happens gradually or is it acute?
Yeah, so this is a great question and probably a more complex topic than I have time to go into in detail. But suffice it to say that about half of all dissections happen in people who do not have aneurysms. They have no evidence of aortic dilation beforehand. So it's not just about the growth of an aneurysm or even being able to predict when a dissection will occur. What we know from studies of exercise is that it actually changes the composition of the aorta. So in healthy people, you can actually build up layers of the aorta from exercise. And if we study the aortas of athletes, for example, they look quite different than people who don't have high levels of activity. The idea here is that by exercising, you're building up an armor around your aorta, and it prevents not only the risk of dilation, but also dissection over time. We don't have long-term data. That's the reason we want to do the clinical study and follow people while they're doing the exercises.
Wow, very interesting. I'm trying to think. Josh, do we have any more out there?
Let's take a look. Chat is quiet.
Okay.
Okay.
It,
I have
and
one. You want me to do the last
go ahead,
question on
Carmen.
here? So I do have one, that we say lifting light weights is okay as long as we stop before or before you can't do anything more or another rep and avoid the Valsalva maneuver. But do you think we'll ever get a clearer direction of lifting weights through the clinical studies? Or are blood pressure spikes from weights just too individualized?
Yeah, so the answer is that what we found when we supervised patients in the exercise study is that blood pressure responses depend on a lot on technique. Even if it's say an arm curl with one arm, you can raise your blood pressure to 250 systolic. It's certainly possible if you were not doing it correctly. So it has to do with the speed. Like, are you going slow and steady versus, quick repetitions, the number of repetitions, and your breathing. And all of that can be trained. You can learn to do it where it doesn't impact your blood pressure. But if people aren't paying attention, there can be huge variations in their blood pressure response to just simple light weights. It is that for that reason, it is very difficult to predict in a given situation how blood pressure will respond unless we actually monitor that person. And that's the reason why I recommend that somebody who's starting out, they go with a trainer to really learn how to do it properly, because even though it may seem like a light exercise, it can have major consequences for your aorta.
And I do want to
Right.
say, you said about people going to a trainer if like they don't have cardiac rehab to still find a trainer. I did not get referred to cardiac rehab, and I did just that too. And although it feels weird to go to maybe a gym or a CrossFit place or whatever to find a trainer, it doesn't necessarily mean you're doing all the things that everyone else is doing. But like you said, it's just having somebody to help you along. But you can also ask your cardiologist or your cardiovascular surgeon for that guidance. I mean, that's what I did starting off as well, because I wasn't given any guidance. So I just kind of asked questions and then took it to the trainer and said, can you just kind of build something that I can do around these do's and don'ts? And so I like that you said that, because there's a lot of patients that don't have cardiac rehab to get started.
Yeah, and I should say that we are currently doing a study with trainers, physical therapists, and occupational therapists as part of the Marfan Foundation effort to develop guidelines for therapists of all types to work with patients who have heritable vascular diseases. And so part of this is educating them and also developing kind of standards for accommodating the different levels of exertion and potential recommendations around people with dissections and other kinds of arterial disease.
All right, last question, and then we'll let you get to your family. Mark Baumgarten asks about, are there any recommended core strengthening exercises for people in watch and wait? And I guess it's really something we've kind of talked about overall. It's not so much the specific exercise, it's your approach to it. I know in the exercise study, I do leg lifts, and I do hold as we did in the study, and but eased into it little by little, continuing to breathe and stuff. Any thoughts on core fitness?
Yeah, so this is one of the reasons why I think resistance training is an important part of exercise, because we know that people who have aortic disease also have a high rate of musculoskeletal problems like scoliosis, like chronic back pain, like hip pain, knee pain. And by being inactive, you actually accelerate the progression of those conditions and make it harder to move over time. So part of exercise is also being able to sustain your quality of life by improving your movement and reducing pain. And that's a major goal. So resistance training helps by keeping the muscles strong enough to support your spine and your bones, which can take the pressure off some of the nerves and bones and reduce the rate at which that progresses. There isn't a magic bullet for this. Everyone can use their own approach, but the key is to do some sort of guided resistance training on your large muscle groups a couple times a week is what the current recommendations are. 2 to 3 times a week, 20 to 40 minutes at a time, depending on your level of fitness.
Dr. Prakash, you are a gem. I can't tell you, it's like if someone says, well, in our group, we'll post, well, Dr. Prakash says XYZ, everybody's like, oh, okay, then that's what we can do. So you've got real street cred amongst aortic athletes. And we're just so grateful for your generosity, your time, and your expertise. And it really means a lot to us that you're pushing these studies.
Well, thank you so much, Jack and Carmen. And I appreciate all you're doing for the community. If there's any way I can help, I would like to participate and support all of the people out there who have questions about exercise.
All right, Jack, you want to take us out?
Hold on. We have some final exiting thoughts here from YouTube. Molly says, a shout out to cardiac rehab. After every exercise, they ask you to rate the scale of 1 to 15 of perceived exertion and BO readings, BF, and after the ball rolling on your future workouts to get your future workouts. She says, sorry, I'm on my 4-mile beach walk and reception isn't great.
Well, a 4-mile beach walk.
I want to be on a beach walk right now.
Right? She's brag-planing over here. She says, Dr. Prakash, enjoy your family this evening. Thank you for spending time with us and giving your expert info. And Julian says, thank you all.
All right. Thank you, everyone. Good night. Stay tuned for more wonderful videos. They're coming down the pike.